Okay, welcome everybody. Just want to point out we're watching the participants, and I'm sort of slow starting the webinar so that a few more people can join just as the lunch hour is getting started here. Very, very glad and honored that you would join us during your precious lunch hour for our second in a series from the Dementia Care Aware program, where we are here committed to early detection and better care of dementia, particularly focused on the primary care space. And we had our first webinar last month on August 1st to really highlight and bring everybody into the cornerstone of our program, which is the cognitive health assessment. So on our website, dementiacareaware.org, you can find a recording of that prior webinar. For today's webinar, as mentioned, we're recording, as mentioned by Zoom, we are recording so that you can watch this later or recommend it to others. And CME, however, and continuing education credits will be available for those who are watching this live. And right at the end, we'll have a QR code that comes up so that you can take advantage of that. But I'm really, really, really happy today to introduce myself and others for our second webinar topic, which is the impact of early detection in primary care. I'm Anna Chodos. I am the director of Dementia Care Aware, our central program here based at UCSF and in partnership with DHCS. And we have many guests, as I'm sure you saw on our flyer, and it's really going to be an outstanding and fast-moving webinar today. So here is our agenda. As mentioned, I'm Dr. Anna Chodos, and I just did our brief welcome. We're going to move on to hear from Mary Rousseve from the Alzheimer's disease program at CDPH about Alzheimer's disease prevention and public health and all the wonderful things happening at the CDPH level. Then we'll hear from Dr. Sue Borson from the Bold Public Health Center of Excellence on early detection of dementia. She's the co-director of the Bold Public Health Center of Excellence, which is based at NYU and part of a large CDC initiative. So really tapping into some of the national aspects of early detection and prevention. And then I'm going to talk about what early detection means and the implications for direct primary care practice and how we're serving patients in primary care. We'll then talk about the importance of early detection for things like legal and advanced care planning. And we're very lucky to have Sarah Hooper, who I'm so sorry, Sarah, it appears that some of your title got dropped off, but I'll reintroduce you for your segment. But she's the director of the UCSF and UC Hastings Consortium on Law, Health, and Policy. And then at the end, we're going to focus on the importance of outreach and early detection for underserved populations here in California, and the implications of early detection for what we're hoping will be more available therapies to really modify the course of dementia. We're hoping we have some time. We realize we really packed the agenda, but we do hope that we'll have some time for Q&A. So I'll be sure to keep moving us along. And throughout, please, we really welcome you to add your questions to the chat. We'll be monitoring that throughout. And we will also take note of questions so that we can put up a response to your questions at the end of the webinar online, even if we can't do it here today in person. Okay, so I'm going to move along now. We are right on time. So I'm going to turn it to our first speaker, and I will let you introduce yourself again. And please, with every slide, just go ahead and say advance, and I will do so. Thank you.
Hi, good afternoon. I am Mary Rousseve with the Communications and Marketing Lead for the Alzheimer's Disease Program, the Department of Public Health, housed in the Center for Healthy Communities. Thank you for inviting me. This is an opportunity to let folks know what we're doing at the Department of Public Health to address Alzheimer's disease. Next slide. The program is focused on prevention and risk reduction of Alzheimer's disease, with a focus on working with disparate communities or reaching disparate communities. The department isn't alone in addressing Alzheimer's, and instead is a major player in collaboration with people like you and with the Department of Healthcare Services, the Alzheimer's Association, Department of Aging, the Governor's Office, and many more. With that work over the years, our work is huge, and we've, as you will, because of the agenda is packed, you'll see there's quite a bit happening. In 1984, the legislation was enacted that established the Alzheimer's disease program. The program was established to meet the legislative mandates of relieving the human burden and economic cost of Alzheimer's disease and related dementias, ADRDs, and to assist in ultimately discovering the cause and treatment of these diseases. The program established and administers a statewide network of 10 California Alzheimer's disease centers, the CADCs, at university medical centers. Established and administers the Alzheimer's Disease Research Fund, which awards grants through a competitive process to scientists in California engaged in the study of ADRDs. In 1988, the Alzheimer's disease program expanded with Senate Bill 139. In 2018, we received funding for Alzheimer's disease and related dementia research through, in addition to the Voluntary Tax Contribution Fund. 2019, we were able to fund California Healthy Brain Initiative local health jurisdiction 6 projects. Next slide, please. And also in 2019, we provided additional funding for the ADRD's research awards funded from the 2019 Budget Act. Excuse me, just one moment, please, sorry. Sorry about that. In 2020, we received support along with other agencies for Alzheimer's disease awareness, research, and training, and that was through the 2020 Budget Act. And most recently, we received funding to refund the California Healthy Brain Initiative projects, and that's through the 2020 Budget Act. Thank you. Why our work is important. The burden is large. The third leading cause of death in California in 2019. The impact is major. California is home to the largest number of family caregivers, 1.2 million in the nation. The total value of unpaid care is estimated to be worth $18 billion annual in California. These are just some of the reasons why our work is important. Next slide, please. By 2030, the number of Californians with Alzheimer's disease will double to nearly 1.2 million. No matter what the ethnicity, 1 in 6 California baby boomers, those born between 1946 and 1964, will have Alzheimer's disease. California is home to more people over age 65 than any other state, and that number will increase exponentially as the population ages. Next slide, please. We have learned there is a huge opportunity for preventing ADRDs through modifying specific risk factors and related health behaviors. Based on the Lancet Commission's article on dementia prevention, intervention, and care life course model, modifying 12 risk factors might prevent or delay up to 40% of dementias. Contributions to the risk and mitigation of dementia begin early and continue throughout life, so it is never too early or too late. The modifiable risk factors include early life, which can include less education, the midlife, hearing loss, traumatic brain injury, hypertension, alcohol, obesity, later in life, smoking, depression, social isolation, physical inactivity, diabetes, air pollution. And in terms of our work at the department and our work at the Alzheimer's disease program, we're housed in the chronic disease control branch, and we have programs that address hypertension, heart disease, and diabetes. So we're in a good position to work together even within our branch to address these modifiable risk factors. Next slide, please. Now I want to provide a little bit of background and overview of the work we're doing and the projects that we support. The CADCs are the backbone to our program and our longest standing funded projects. There are a total of 10 California Alzheimer's disease centers. The CADCs are established to improve dementia healthcare delivery, provide specialized training and education to healthcare professionals, and advance the diagnosis and treatment of ADRDs. Each CADC receives $281,000 each year in state general fund revenue to support their diagnostic and education mandate. Many CADs are also federally qualified Alzheimer's disease research centers. These include, the CADCs include University of California, Davis, University of California, Davis East Bay, University of California, San Francisco, UC San Francisco, Fresno, Stanford University, UCLA, University of Southern California, University of Southern California, Los Angeles, and Rancho Los Amigos, University of California, San Diego, and UC Irvine. Next slide, please. This is just a highlight of the projects that, additional projects we support and who we are in terms of our Alzheimer's disease program and the projects that are currently in play. So including the CADCs. In 2019, ADP was able to fund 6 local health jurisdictions, the California Healthy Brain Initiative. These are our community-focused programs, and it was a 2-year project. They work with community-based organizations. It was a 2-year pilot project that just ended in June 2022. We received additional funding to expand the program through the Budget Act, 2022 Budget Act. So we hope to have additional projects in place soon to further the work at the community level. In addition, we have the research projects, which we are able to fund. As I mentioned before, we've received additional funding to provide funding to more research projects to continue the work in researching Alzheimer's awareness, Alzheimer's disease and related dementias. We most recently started put out a competitive bid process to secure an advertising agency to create and to develop and implement a diabetes awareness campaign. We're excited about that. The applications are due this Friday, and we hope to have an advertising agency in place March 2023. That will support all the work we're doing, and through marketing, research, and focus groups will be able to fine tune to ensure we reach the audience we want to reach, and will include screening. So for the work that we're doing here. The standards of care, standards of dementia care is another focus area, caregiver trainings, and dementia-friendly communities. At this time, I can provide very high-level information on the standards of care and the caregiver trainings. The standards of care, we're working with government and community partners that directly support and administer Medi-Cal and Medicare managed care activities, including the California Department of Healthcare Services, to explore the incorporation of dementia standards of care, leveraging the expertise of the 10 CADCs. For the caregiver trainings, the intention is design as funding is available, a caregiver training and certification program that will elevate the care in communities throughout California by expanding access to evidence-based dementia-related education and training for caregivers, unpaid, paid, and in-home supportive services. And then the dementia-friendly communities allocate grants to California cities or local health jurisdictions most prepared and willing to address dementia in their communities. All these projects, the research projects, the ones listed on here, support the master plan on aging and come out of the 10 recommendations from the governor's task force. So this is our role in public health and the work we're currently doing. I just wanted to provide a high level today introduction to our work with the idea that we would provide more information later, maybe at an upcoming webinar in another forum, but I'm sure that we will remain partners and be part of your work in some way in the near future. Next slide, please. So if you had any questions for us in general for the program, the best way to reach us is through our email at the alzheimersd@cdph.ca.gov. Thank you.
Thank you, Mary. Thank you so much for that high level overview. I think what we can really appreciate is just like how much is going on and at all these different levels to really, support and kind of grow a lot of the strategy for standards of care out of the CADCs, and then really try to reach everybody from, general population to the healthcare providers that might be here today. So
Yes,
thank you so much. I also love, and I think a lot of us have seen that Lancet flow of all the risk factors, and something that always sticks out to me, other than early life education, which is so important from a public health standpoint, but tricky policy wise maybe, is the hearing loss issue, which you brought out and just really spoke to me again. I wanted to highlight for the participants that hearing loss as a modifiable risk factor in middle age, especially with wider access, hopefully, to hearing aids now, although a lot of that is for Medicare beneficiaries, it would be really, really important as a modifying risk factor to prevent hearing loss. So Mira, I just want to say thank you. And that would be incredibly wonderful to have you back. So thank you for that offer. We are going to move to our next speaker, Sue Borson, and I will let her introduce herself, but this is again a nod to some of the really big things that are happening in early detection. Thank you, Sue.
Thank you very much for inviting me. So I'm going to tell you very briefly about what we're trying to do in the Bold Public Health Center of Excellence on early detection of dementia. As many of you know, the BOLD Act from 2019 empowered CDC to create centers of excellence and a series of largely state-based programs to establish public health infrastructure for dementia risk reduction, early detection and better care, and caregiver support and assistance. So our focus specifically at the BOLD Center on Early Detection is on early detection, establishing and collating the evidence that exists today about what tools and what strategies are most helpful and in what setting. And I'll tell you more as we go. So next slide, please. So, but our orientation is this, and I think it's important to spell out exactly what we're trying to accomplish, because we tend to make assumptions in this field that early detection is going to produce better outcomes. Well, the evidence just isn't there yet. Hopefully, it will become there. We'll understand in what way early detection really matters. What we're left with right now is a series of stories from people whose family member had late detected dementia and describe in painful detail the consequences of that lateness for their lives, their relationships, and the health of the person with dementia, sometimes the health of the family itself. So we would like to move in the direction of promoting the development of evidence, but that is not our major mission. Our message is that dementia is a manageable chronic condition, like many other chronic conditions. It isn't a death sentence. It isn't a catastrophe, although catastrophic effects do occur. And our goal is to reduce the likelihood of catastrophe through early detection and planning. So early detection before a crisis occurs, proactive management of patient in the context of their natural care environment, that follows simple and proven principles, which are multidimensional and multi-domain in dementia care, but center ultimately on relationship, the relationship between the person, the family, and what we might think of as the primary dementia care provider. And that may be different people. And lastly, the principle of working as a team cannot be overestimated, and it's an enormous challenge in the early detection space because we don't have teams that work as teams yet in most of our healthcare systems. Next, please. So what is our mission? It's to make early detection of dementia a routine practice across the United States. And so Dementia Care Aware and its emphasis on detection in a population is really a foundational effort that supports the work of the BOLD Center indirectly. It's also to make evidence about early detection tools and strategies available to everyone who's interested in them, especially through publication on our website. then to discover and to co-create solutions with stakeholder organizations and communities nationwide. Next, and to promote implementation of effective, sustainable public health, clinical, and community initiatives focused on improving early detection, reducing stigma associated with dementia and with caregiving, and advancing health equity. Lastly, to empower individuals and stakeholder groups to create pathways from detection to evidence-based care. How are we doing it? Well, we think of our work as falling into 3 buckets. First, we simplify. We're trying to arrive at simple steps to help with dissemination of detecting cognitive impairment and clinical pathway development. We have real-world examples of successful strategies that we are collecting now through our partnerships with other BOLD and Healthy Brain Initiative funded programs and others. Our second step is to amplify, to magnify, if you will, by highlighting innovative early detection work. And that includes Dementia Care Aware. And to showcase actionable efforts that are adaptable to diverse settings. Next. Lastly, our third step is dissemination. We spread information about evidence-based practices and strategies to increase early detection, provide technical assistance for capacity building, decision-making, choice-making, and strategic planning, and facilitate insight exchange across states and between engaged organizations. And at this point, we have a number of engaged organizations beyond state entities and county entities. We have US Aging is a partner with us that hosts dementia-friendly communities, Dementia Friendly America. And we have a number of organizations who are now working with us to share insights and help us get the message out. Next, please. This is a beautiful lighthouse from Duluth, Minnesota. It's one of the most beautiful lighthouse pictures I've ever seen, and it depicts the idea that we hope we can exemplify over the course of our work in the next few years, and that is to bring light to a difficult and contentious issue, and to show the way with the help of all of our partners in how to do a better job to care for our patients with dementia and their families. Next. So please, if you want to be in touch, and I would hope that some of you would like to be, please find us here. This is our website. And next. And please register for our symposium on October 25th to 27th. Dr. Chodos will be there. There will be many innovative programs featured in this symposium, and there will be ample opportunity for conversation among attendees. So this is how to register. We hope to see you there. Thank you.
Thank you, Sue. As usual, very inspiring, and I think good segue into the content that I wanted to bring to the webinar today on how we can really bring some of the kind of concepts and thoughts behind we really need to be doing more early detection. This can clearly benefit patients too. What does that really look like in the primary care realm, which is what I'm going to talk about. So and I just wanted to thank you as usual for your very inspiring presentation and approach to this work. And that indeed was a very beautiful and inspiring lighthouse. I wanted to remind everybody, and it says it in the title, this symposium is virtual, so it's highly accessible opportunity. And for us in California here, it's 1 to 5 East Coast these 3 days, so it's 10 to 2 or so for us in California time, so very doable. Thank you so much, Sue. So I'm going to move right into what it might look like for us to be doing more early detection in primary care. And I really welcome your comments and thoughts. I'm sure there are many. I think just to state the obvious, and this is thanks to our last presenter, Serggio Lanata, a graphic that he's using, so I thought I would call on it as well. I think we're all aware that naturally progressive history of the diseases, the neurodegenerative diseases that lead to dementia syndrome, are that they're very probably active and progressing for a long time before we detect them clinically. So if we imagine that really the pathology starts here, but there's really no clinical implications until things start to get into the red zone, we can't even really detect it quite yet. I know there's, fancier methods out there, but maybe clinically, syndromically, symptomatically, we can't really detect it before there start to be clinical implications and symptoms. But the point is that what a lot of the data shows is that we really are detecting it quite late in the course of the disease. When some symptoms are present, it's really theoretically possible that we could be detecting it earlier. So the goal of early detection is really to get closer to that point that would be, most feasible, most realistic to detect. And let's see here. So who are the stakeholders? Who are we thinking about as really being engaged in the early detection process? And I know a lot of us are probably thinking, rightfully so, about the patient, maybe should be at the center here. But I think a big emphasis of the Dementia CareWare program is that we're also thinking about that person's caregiver and care partner. A reason for Sarah Hooper being here today is that we're also thinking about community and social service providers, including legal services, that might be stakeholders and engageable as well in early detection. The rest of us here in the healthcare field and primary healthcare, we are clear stakeholders. We've got something really invested in early detection, as I shall explain. And then specialists as well who are engaged in really supporting us in the full diagnostic process and care planning for dementia. We really hope that the specialists are engaged in supportive of early detection as well. And the big picture, again, as my prior slide showed, is that we know that so much dementia is being missed particularly early, and that up to, good best case scenarios that about 50% of dementia is diagnosed and documented, particularly in the milder and earlier stages. And we're all invested in improving this number, this amount of detection. And the good news is there's a lot of work to do. But I'm really focusing on these three as I think about the primary healthcare environment. And so, of course, the ideal scenario, and I think Sue was getting at that, we don't necessarily have evidence that we have a lot of evidence that there are benefits to early detection, but I think it depends on how you frame those outcomes. And so one thing that I might say is that an ideal scenario that we can imagine in our minds is that someone has mild symptoms. We can deliver a timely diagnosis, and timely really emphasizing we can't always necessarily know where we are in the early or preclinical stage, but that it's at least timely to when they're presenting with symptoms, and hopefully, very mild symptoms, and that we can be very proactive and partnering with patients and their support systems on a care plan and treatment. And this just gives us far more opportunity to do the proactive legal and social needs planning and preventing unnecessary social harm and medical complications when this is not detected. What is clear is that what generally speaking is happening is we're really picking up on it when, in many cases, when people already have really significant or advanced symptoms, meaning more pervasive, more functional impairment. Diagnosis is, in this scenario, would be considered delayed. We probably could have detected it earlier, and we've missed a lot of these opportunities. And we do know that for a lot of people and care partners, the patients and care partners themselves, this does lead to unnecessary stress, unnecessary hospitalizations, potentially early institutionalization. And a really, really big one, particularly as people lose functional abilities, would be loss of assets. So these are the things I think of as real harms to people that are sort of, we know, outside the medical realm, but because of lack of, awareness of the need to legal plan and financially plan, they're in the world very vulnerable and unprotected. So some benefits and there is it's about 10 years old now, but a European consortium really put some finer points on the value of knowing. And I thought a lot of it was really well framed. And I think one thing that really stands out to me is this idea that people with dementia really do have a right to a diagnosis in a timely fashion. It gives them more opportunity, more autonomy around planning and making choices about how the rest of their life is going to go. It can relieve a lot of uncertainty, even though we know there's not a cure we're going to hand them immediately. It can relieve a lot of uncertainty about what are all these symptoms? Why am I having these, bouts of anxiety, or why can't I get it together? There's a real relief in at least knowing a cause, even if it's not entirely modifiable right now. People report feeling more empowered and informed when they have that diagnosis. So this comes to a point of our program that we really want to focus on and develop and offer to you. Our program in Dementia Care Aware is just getting started, but this issue of disclosure, how we empower people with that knowledge in a compassionate and complete way. So we do want to bring, and we'll be putting more resources on how we can frame and do disclosure with patients. And it can lead, again, to just more opportunities. You have more time, you have more opportunities for access to information, education and training for care partners, just more access to care in general, including access to specialty care and opportunities for planning. And really a big goal is the more we can intervene early and support people, the better they do, the more functional they are for longer. The goal, one really big goal, is delaying institutionalization. For primary healthcare, I think we have totally coming right off of Sue's points that this is a manageable chronic condition. So it's chronic and it's pervasive, and it affects all aspects of a patient's care. So it not only affects the dementia itself, and that what we're going to manage around the dementia and all the symptoms that are coming from that, but the other comorbidities. So it's when I'm saying pervasive, what I really hope to invoke is that it's so relevant for all the other care that we're doing in primary care. We might modify targets around diabetes, around hypertension, as I'll mention in a moment. And then the other thing is, if you take our original training in the cognitive health assessment, which really focuses on how we do some of the detection and initial assessment of someone who's older to see if they might have symptoms consistent with dementia, we focus on you can actually start a brain health plan right away. And that is one of the things we can do to help delay progression. So starting the brain health plan, I just want to review, and this is in our initial training, would be something we can do to reduce medication burden that affects cognition, encourage regular physical and social activity, correct hearing and vision. Again, it's a pet thing of mine that we really could be far more aggressive about hearing correction, and controlling vascular risk factors insofar as it's consistent with other comorbidities and implications. The other comorbidities that become really relevant, just as examples, diabetes, loosening our diabetes control, becomes very important, is consistent with current guidelines from major endocrine organizations to loosen, and the American Geriatric Society, to loosen control of diabetes to a goal A1C of less than 8. And then blood pressure goals as well, particularly in our oldest patients in their 80s and above. And finally, just that pervasive notion, again, that when dementia is there, it's really reframing the paradigm of care for this person. And we can really focus on harm reduction and simplifying care plans instead of really trying to optimize every single condition. We're really trying to focus on a practical self-management strategy for this person that involves care partners, but gives people really practical options for management that is consistent and synergistic with someone who has dementia. The other thing, and we will have additional webinars and topics to address this as well, is how we can work with care partners and caregivers. And the main points I wanted to make is just how foundational this person is to the health of our patient with dementia, who's living with dementia, and we need them to help us with health and functional needs. I totally acknowledge that many patients do not have a care partner they can identify But if they do, working with them to think about what can I do to support that person, giving them more opportunity to encounter education and training resources, and asking that care partner and the patient how they want that person involved. What is their relationship really like? How can I lean on this person and not just assume that that person can take on, the full, heart failure management plan. And so I think what we're really hoping to do, and we really hope you continue to engage with this program, email us, let us know what would be helpful to you as primary healthcare providers and primary healthcare teams, is we want to provide that education and training on this detection piece, as well as on the diagnosis and care planning piece. And we want to support you as a provider and as a practice in starting to incorporate some of these resources and training opportunities into your practice. So we are here, and we are at dca@ucsf.edu, and you're also always welcome to email me personally. And I'm going to quickly transition to our next speaker so that we can hear everything she has to say about the importance of early detection for legal and advanced care planning. And Sarah, I will turn it over to you.
Great. Well, thanks for having me, Anna. It's a real delight to be a part of this project and a part of this work. I think I'm here to provide the perspective of, I'm a lawyer and law faculty at UC Hastings Law in San Francisco. I direct our health law and policy program and am the policy director of our medical legal partnership with UCSF. And I've worked with clinicians very closely for over a decade now, thinking about how we can work together to improve care of older adults, in particular by helping to address social determinants of health and sort of addressing the care needs that are outside of the clinic walls, but deeply, deeply affecting their health and health outcomes. And can I get the next slide, please? Sue correctly mentioned that what we have are a lot of stories, and we have a burgeoning literature around complex care and sort of what outcomes look like for older people with complex medical and social need. But I actually wanted to bring a story into the room because I feel like it's for those of us who have not been personally touched by dementia or by these issues, you may not sort of be aware of the risks for sort of failing to address these needs early or comprehensively. So I want to tell you about Mr. S, who was a 72-year-old man who lived alone in Northern California. He had very low income and he lived on about $24,000 a year. He was close with his neighbor who checked on him periodically and who was concerned about how he was managing on his own. And one day, Mr. S called the neighbor to ask if cat food was safe to eat. And the neighbor this was the last straw for the neighbor, he decided something needed to be done. So he packed Mr. S into the car and drove him to a hospital where he thought the hospital staff could do something. So the hospital staff evaluated Mr. S and determined that he had previously undiagnosed dementia and COPD that had been not managed in a way that we would have liked. And they determined that while he did need help, it wasn't actually hospital level care that he needed, and he would be better served in a long-term care facility or in his home with more support than he was getting. So they looked into long-term care options and encountered many barriers getting those. They had questions about Mr. S's capacity to manage things on his own, and he didn't have a legally appointed caregiver to navigate these things for him. So the team decided that conservatorship was the answer and that the public guardian would be able to get him into long-term care. The process of figuring out Mr. S's discharge plan took months, and the conservatorship process was going to take more. And throughout this process, Mr. S was growing increasingly depressed, living in the hospital, and he said it felt like prison. But he couldn't articulate a plan for how to live safely at home. And so the team didn't feel comfortable letting him go. And Mr. S ultimately lived in the hospital for 6 months. and he died of a complication before he could leave. So this is a catastrophic story. This is a very sad story. And it's an exceptional story in some ways. But in other ways, this is not an exceptional set of circumstances, in that we know that when people do not plan, they are at high risk of extreme interventions like conservatorship. And when people don't plan, and when they aren't given the supports that they need in the community, they are at higher risk of unnecessary and preventable hospitalization, longer length of care, and or sort of failure to thrive in the community. So a whole constellation of things failed Mr. S here. And there are things that we together can do better. Can I have the next slide? So first, early detection, of course, as Anna described, could have helped put a brain health plan in place for Mr. S. It could have, as part of that early detection process by a primary care team, raised the need for him and identified the need for social workers, caseworkers, others working with him to identify legal decision makers, right? And to help him plan ahead. So we think of this as incapacity planning. So in the healthcare system, we're usually thinking about planning as being around decisions about death. But for people with cognitive decline, the critical trigger is loss of capacity for legal decision making. And we know that that is something that could be coming and is something that is eminently addressable through good planning. So we need medical decision makers, we need financial decision makers, because people like Mr. S may have 3 potential payers of his care, none of whom talk to each other at all or effectively, and his caregivers need to be able to manage his benefits and his finances in order to get him access to the resources that he needs. And in particular, if you have someone like Mr. S who doesn't have a clear decision maker, that makes it all the more important that we address this early while he still has capacity to do some planning himself. Because he may, for instance, be able to choose that neighbor. He may be able to choose private fiduciary, somebody else. But if we wait until he has progressed and no longer has capacity, we have very limited options in what we can do for someone like Mr. S. Food access is another critical thing, right? The phone call that started this hospitalization was a question about food and whether cat food was safe to eat. We have these resources in the community. It's a matter of linking people to them. And finally, long-term care advocacy. We have a deeply fragmented system of long-term care supports and services, again, with different payers, mostly not paid for by Medicare. And so we need to help people understand and navigate these services so that we can help prevent that hospitalization, we can help delay institutionalization. But what that requires is understanding how benefits and personal assets and resources work together to make it possible for somebody to actually access those supports. Next slide, please. So this may seem very overwhelming. I understand that this is sort of well outside of what a lot of primary care teams are worried about. But here's the good news. The good news is that we have lots of people in the community who do understand these systems and are experienced at navigating these things with and for your patients. And the Older Americans Act was passed in 1965 and created a whole federal, state, and local network of resources and supports for older people. So access to services, nutrition, home and community-based services, and legal assistance, free legal assistance, particularly for high-need older adults with a need for things like accessing public benefits, advanced care planning, housing, and prevention of elder abuse and neglect. So we have these resources in the community. What we haven't done effectively is connect our healthcare system to these social care services more effectively to ensure that the patients like Mr. S, who have the greatest need for them, are accessing them in a timely way and not after it's too late and we have very limited options. Next slide, please. And we know that even though people like Mr. S have a greater need for these services, they also experience the most barriers in accessing them. So for instance, we know that about 56% of low-income seniors had a civil legal need in 2017. Mr. S falls into the category of the 10% of those older adults who had more than 6 civil legal needs. And although they have a great number of legal needs, 86% of these older adults who are surveyed received inadequate or no legal help. And when asked why they didn't receive these services, the top barriers were that they didn't understand that they had a need and they didn't know where to go for help. And so to me, that is great news, right? That is great news because that is something that is a gap we can close. And so we are hoping to do that as part of the work that I've been doing for the last decade and also as part of the Dementia Care Aware project. Next slide, please. So what primary care is really well situated to do is to identify those needs early. So to detect when someone is in need of advanced care planning. And frankly, we all are in need of advanced care planning. So this just becomes particularly relevant in the context of cognitive health assessment. You can detect, you can counsel patients and caregivers that these resources are available and that it's important for them to try and access them. And then you can refer. And we are, next slide, please. More good news. As part of the Dementia Care Aware project, we are leading a statewide medical legal collaborative that is developing training and resources to help clinicians understand when to screen for these needs, how to do that, and where they can refer patients and caregivers for help. And so that is hopefully some good news. It feels like a very big problem clinically, but I can tell you that these problems socially and legally, we have a lot of tools for addressing them. And what we need is to meet people like Mr. S before these issues become a crisis. And we're excited to partner with everyone here in that work. So thank you.
So I'll just plug Sarah as a contact. And as usual, Sarah, thank you for like all the calls to action and feeling really practical and applied in terms of what I think for a lot of us in primary care feel is like, how do we really connect and pointing out that we hope to have more resources. I'm going to transition to our last speaker, Serggio Lanata, who is going to talk about the future implications for future therapies, as well as the importance of early detection for underserved older people in California. And I just want to point out, his will be the last presentation of approximately 10 minutes. And then we're going to have hopefully a time to address a couple of questions. You could get them into the chat in the Q&A now. We'll put up the QR code for the CME and continuing education credits that you can scan with your phone. And then we will also have a very quick poll to hear from you very quick about how you learned about this webinar, because we do want to do a better job of outreach and getting more people to these webinars in the future. So thank you in advance for that. Serggio, I'll hand it over to you and thank you.
Thank you. Thanks for the opportunity. And I am part of the project here supporting the educational core, and I'm here to talk to you about the importance of outreach and early detection for underserved, vulnerable populations in California, and then a little bit around therapies as well that I think is important for you to be aware of. I'm going to center my conversation on this chart that you saw before, and just to highlight that this is what the natural history of a neurodegenerative disease, with Alzheimer's being the most common neurodegenerative disease worldwide, this is what the natural history looks like. People go through these stages of having a healthy brain, meaning that there's no pathology brewing in the brain. Then they enter an asymptomatic stage where there is already pathological changes happening in the brain, but as far as any clinician can tell, the person is doing fine, both cognitively and functionally. Then the person will enter a stage that we are now calling subjective cognitive decline or subjective cognitive impairment, which basically means that the person is noticing some signs of change, but these cannot be substantiated on interview, examination, or cognitive testing. Then they enter a stage that we know as mild cognitive impairment, and the DCA is helping us identify people in this stage, which is basically someone that is having cognitive impairment that can be substantiated on cognitive testing, but functional abilities are still relatively well preserved. And it's not until later that, as you heard before, that a person meets criteria for what we call dementia, in this case caused by a neurodegenerative disease like Alzheimer's, where the patient is really severely impaired cognitively and functionally. This understanding of the long natural history of Alzheimer's disease and other neurodegenerative diseases has propelled a lot of research around primary prevention. Next slide, please. And looking at this from the perspective of AD pathology, this is what we understand in terms of the disease, that all of these biomarkers, all of these pathological changes are happening years, sometimes a decade before, and specifically the accumulation of amyloid protein and tau are happening a decade before a person transitions from being cognitively normal to having MCI and dementia. Next slide. And like I said before, a lot of research into the risk factors, and here we list the medical risk factors that you've seen in a previous presentation and associated behavioral risk factors. And research is now trying to identify, what is driving these behavioral factors and risk factors, and that brings us to more upstream factors, meaning the social and environmental factors some of which I list here. So all of this cascade is contributing to the outcome that we're interested in, which is, neurodegenerative disease, AD, and cerebrovascular diseases. So this frames both the research and also, I would say, the clinical agenda of our work. Next slide, please. Because as research is showing, people that live in neighborhoods, regardless of what race they belong to, people that live in highly vulnerable neighborhoods tend to have lower cerebral volumes, and specifically also lower hippocampal volumes. And this is the prime territory for Alzheimer's disease. So this all is guiding our approach to outreach here in San Francisco. What you're seeing here is a map that shows different levels of vulnerability, social and environmental vulnerability across different neighborhoods in the city, with red being the most vulnerable neighborhoods. Not coincidentally, due to historical reasons, these are the neighborhoods where most of the racial and ethnic minorities live in San Francisco. And to the right, you see where our patients and our research participants are coming from. Bigger the circle, the more representation we have from those neighborhoods, the smaller, the less representation we have. So this understanding, the setting of everything that I've already mentioned, is guiding our approach to outreach here in San Francisco, meaning that we've partnered with organizations within these vulnerable and underrepresented, underserved neighborhoods to try to bring education around the brain, to try to bring workshops and incentivize people to come to clinic and also to participate in research. Next slide, please. And I'm just showing you a recent graph that we put together for our Alzheimer's Disease Research Center, looking at what type of diversity we have within our existing participants. As you can see here, most of our participants are not Latinos, are not Asian Americans, Chinese Americans. They're from other groups, but because of the work that we've been doing, we've been slowly going up on our representation of Chinese Americans as well as Latino Americans, most of whom come or live in vulnerable neighborhoods and vulnerable regions, meaning that the outreach approach that we're doing helps. And I think this could be something that could happen anywhere in California, obviously, with enough support and resources. Next slide, please. You saw a map earlier about the representation of Alzheimer's disease centers in California. These are primarily state-funded. Well, this is a map of Alzheimer's disease research centers, which are mostly funded by the NIH. As you can see here, California has 6 of them, and this would be excellent sites of referral of people from vulnerable backgrounds, even so that they can get a comprehensive evaluation of their brain health. And as I already showed you, I think personally, based on my experience here, It is not true that people from vulnerable backgrounds are not interested or even unable of participating in research. They are. It just takes a lot of work, obviously, and a lot of community-based action to make it happen. But it's tremendously beneficial not only to our common understanding of these diseases, but also to the participants themselves, because they get a lot of feedback back from us. Next slide. And just to further highlight that point, we were able to apply our ADRC evaluation practices to a cohort of persons that were experiencing homelessness here in California, and they were able and they were very interested in participating because they see changes, they feel changes to their brain health. Next slide. Okay, now transitioning to the issue of research into clinical trials. I think the main point I want to get across here is that in recent years, there has been a dramatic and unprecedented increase in the number of clinical trials focused on identifying, focused on finding a disease-modifying therapy for Alzheimer's disease, because up to this point, all we have are symptomatic therapies. We don't have any pharmacological therapy that truly slows down the progression of this disease. And what I would like you to appreciate is that most of these compounds here are targeting tau and amyloid, the tau and amyloid protein of Alzheimer's disease. And of all of these, the only one that has made it to some reasonable, at least clinical benefit, not clinical, but biomarker benefit is aducanumab. And as some of you may know, Medicare has a conditional approval on aducanumab right now, meaning that we are able to prescribe it for Medicare patients as long as the patient is enrolled in a clinical study. And I put this slide here because more is coming. There is now an increasing amount of compounds that are being studied, especially targeting tau now, because the amyloid protein molecules have not been too successful. Next slide. And many researchers think that the reason why these compounds have not been successful is because we are screening for these disorders too late, as you've already heard. And people that were included in these studies are already in the late stages of disease when the brain has already suffered neurodegeneration. And, you know, the point is we need to learn to identify these diseases, AD and other neurodegenerative diseases, earlier and try to enroll these people in clinical trials, the ones that are willing, because that's where the future will take us. It will take us to a point where we're going to use these drugs, not here, but more in this realm. Next slide. And just to finish, this is an example of a study that is being conducted right now. And it's recruiting people across the country, including Latinos and minorities that are asymptomatic. They don't have any signs of cognitive impairment. And the goal is to even attack this disease process before it begins clinically in asymptomatic stages. Next slide. This is the AHEAD study. We are one of the participating sites, but you can see here that it's widespread throughout most of the country. And like I said, there's an active effort to recruit people from underrepresented vulnerable groups. Thank you.
Okay, well, we did run up right against the hour. I thank you guys for turning your cameras back on to the speakers. I just want to thank you, really appreciate it. My team is going to put up that brief poll that we talked about. I think that actually might be the last slides. We'll take 1 second. Oh, it's already up. So go ahead and respond if you can. I do want to point out, since we have 30 seconds, in addition to my gratitude, is that understandably Sarah's case about Mr. S and the resources, trying to improve support and resources for us working with really vulnerable people in the community that need legal help early and not getting in these situations of, you know, kind of their whole lives coming undone and needing emergency and crisis response from county services. That this really touched off a lot for people, that his situation was one where a lot more could have been done. And I guess, Sarah, I don't know, I'll give you the last word, and then I'll put up the CME code so that people can get their CME if needed. And go ahead and unmute yourself, Sarah, and then we will wrap up.
Sure. Yeah. Thanks for this commentary. It's a really important issue. I'll just say that you're right that the Public Guardian's Office is overwhelmed. And that is all the more reason why we need to do advanced care planning so that these issues aren't ending up in the Public Guardian's Office. And what I will say is that other agencies exist. So for instance, I mentioned legal aid is a service that has long been funded under the Older Americans Act. And that is the place where you do advanced planning. The Public Guardian's Office is where you go when other things have failed. And what I have found in working with hospital teams and other clinical teams is that we make the leap to guardianship often a little prematurely. And so what we can do is help think about social and legal need identification and triage, making sure that we're identifying decision makers before someone has lost capacity, helping teams understand legal definitions of capacity as well, and when someone is actually able to make a decision and when they're not. So it's a very complicated topic. I'm sure we could have a whole webinar just on this issue. But you're right that there are some resources that are strained, and that is why we should think about utilizing other resources in advance so as to take some pressure off of hospitals and public guardians offices. Thank you.
Great. And Mary, you had your hand up and I'll let you have the last word. And to all of our participants today, thank you.
Thank you. I accidentally raised my hand, so I'll let you have the last word.
Love it. Okay, well, Mary, yeah, it was full circle. Appreciate it. Thank you so much. I guess all I'll say, I've already put in the chat, we do want to hear from you, however we can support detection at any level, but certainly with resources from the Dementia Careware program. So we readily share our email and we hope to hear from you. And thank you so much, Mary, Sue, Sarah, and Sergio for joining me today. Have a wonderful afternoon.